Morning, students. I'm here today to talk to you about Chapter 25, and you're also going to hear some content that is not actually in 25, but you will be responsible for that content as well. And you may even hear some of this information that I'm giving you again today in pediatrics. Let's talk a little bit about birth trauma. When one considers the amount of strength and compression and passageway available for the birth process to take place, it's easy to imagine how these injuries can occur. Here we will discuss the two most commonly seen birth kind of traumas, which is skeletal and neurological. When we look at skeletal, one issue that we see that can happen is called fractured clavicle. And it will occur if the fetus is unable to adjust appropriately to the mother's pelvis, or if the passenger, again, the fetus, presents to the mother's pelvis in what's called an acyclitic fashion. Acyclitic meaning off-center. We also see retinal subconjunctival hemorrhages due to a capillary rupture and the pressure. That should resolve in a couple of days. Two issues coming up that I'm going to be talking to you about that is seen more frequently. One is called a caput, which is an edematous scalp, extends and it crosses the suture lines. While we have a cephalohematoma, which is specifically a collection of blood that does not cross suture lines. So when you go to think about the two of those, I want you to think about caput as a cap that covers the entire head, where a cephalohematoma does not. Both of the above issues are on page 570. Neurologically speaking, we can see things like an Erb's palsy, a brachial plexus, and both are self-limiting. Care in trauma cases includes rapid identification, monitoring, assessment of secondary complications due to trauma, and with regard to skeletal issues, in some cases, medical treatment may include bone stabilization. Okay, here you can see a really good picture. On the right, there's an Erb's palsy baby. You can see how the arm is kind of laying there a little bit limp. They can move their fingers and such, but it does have a difficult time in moving. On the right-hand side, you see a real good picture of a fractured clavicle. Sometimes what will happen with a fractured clavicle, we'll have the baby's arm that's in the t-shirt. We'll bring that t-shirted arm over across the chest and pin it to the t-shirt to kind of stabilize it for a couple of days. Okay, students, I'd like to show you here the classic signs of sepsis. Respiratory distress, I'd like to call your attention to that. Those are the three gold standard signs that we see in a baby that is either septic or becoming septic. Some of the other outward symptoms include lethargy, hypoglycemia, and temperature instability. Sepsis infection can be categorized in three different types: maternal, neonatal, or intrapartum. Pathophys of newborn infection is typically as a secondary infection attributed to an ascending infection from a positive screen mother. Through exposure to maternal blood or body fluids, susceptibility high in newborns secondary to immature ability to produce antibodies. High-risk groups include, but aren't limited to, maternal premature rupture, prolonged rupture of membranes over 24 hours, positive maternal screen for infective agent, and meconium aspiration. Assessment includes symptoms that mimic RDS, and on x-ray we see what looks to be like a ground glass appearance. Temperature instability is primary. hypoglycemia and poor feeding, tachypnea with periods of apnea, pneumonia, meningitis, and lethargy. Treatment includes supporting organs and symptoms affected by infection and modalities specific to that type of disease. Okay, let's talk about ophthalmia neonatorum. Newborns can become infected at birth from a maternal undiagnosed gonorrhea or chlamydia status. Prophylactically treatment is done at birth with administering EES, which is erythromycin ophthalmic, to both eyes at birth. Infected newborns, ones that are born with gonorrhea or chlamydia, is individualized. We see IV ceftriaxone or penicillin, and we also treat the mother. Okay, let's take a look at 3 maternal infections that are significant for our babies. The first one is GBS. The neonates that are at greater risk include those that are being born to a mother that has tested positive for the culture, and especially if she has prolonged rupture of membranes, anything over or greater than 24 hours. If there's no treatment, and this is the early version meaning that the fetus contracted this while in utero, 20% will die in the first 24 hours of birth. Management includes antibiotics to the mom during labor, and afterwards we need to monitor the baby very closely, including CBC and blood cultures. Now, when we talk about herpes or HSV, if the mother contracts a primary infection, which means, again, the first time that she has had HSV was while she was pregnant with this fetus, that will cross the placenta to the baby, and the baby will be born with vesicles. Prognosis, however, is hopeful, especially if treatment begins at the onset of pregnancy. If acquired at birth, day 4 to 5, we're going to start to see signs of sepsis, sometimes sooner than that. If no treatment is begun, this baby will become severely ill, and death will occur between hours and days. Treatment is Zovirex. Prevention includes antenatal antiviral treatment. Hepatitis B. When mom goes to the doctor for her first visit prenatally, she is screened with what is called a maternal hepatitis B surface antigen. If she screens positive for that, it can be transferred to the baby at birth through body fluids. So as you can imagine, the first thing to do just about is bathe that baby. Treatment includes gentle suctioning of oral cavity after birth and withholding any IM until after the bath. You also do not want this baby to breastfeed until it's given its HBIG injection. Within the first 24 hours, we need to give this baby the first of the 3 hepatitis B injections and the HBIG. Okay, let's talk about neonatal abstinence syndrome, also known as withdrawal syndrome. In this case, the infant is passively drug addicted from a drug addicted mother. The initial assessment at birth shows a normal appearance, then 12 to 24 hours later, as the serum drug levels drop, the neonate will exhibit signs. Some of those signs are included here. Some of the classic ones include the jitteriness and the high-pitched cry and sneezing. Management includes medication that is individualized based on the drug that the baby is addicted to. We want to provide a quiet environment, firmly swaddled. We can place them in a swing or rock them. Monitor vital signs closely, seizure precautions, expect longer feedings, and accurate I&O. So let's talk about fetal alcohol syndrome here. Alcohol addiction affects the placenta and how well it works. So knowing what we know about the placenta and all the things that it provides for our babies in utero, let's see what some of the signs could be after the baby is born. Of course, we're going to see IUGR. We may see some cognitive impairment with distinct facial features. We may see abnormal palmar creases. We may see RDS, congenital heart conditions, irritability and hypersensitivity, tremors, poor feeders, and seizure activity. Management includes assisting with long-term effects, monitor and assist with RDS, keep resuscitation equipment at bedside, monitor for hypoglycemia, small feedings PRN, and decrease stimuli. This is a picture of what I like to call the unsung hero. All survival for the fetus is found in what the placenta is able to do for that fetus. What I'd like you to notice when you walk away from this slide is that there is no exchange of fetal maternal red blood cells. All right, let's talk about blood incompatibility types. We all know that blood has two factors. One's the ABO factor, the other is the RH factor. When we look at maternal fetal cells, there are two types of incompatibility that can exist between the mom and the baby. The first and the most severe is called an RH incompatibility, and it happens only if the mother is RH negative and the baby is RH positive. The other is an ABO incompatibility, which is less severe, but it also occurs if the mother is type O and the baby is AB or AB. Both conditions warrant close observation of the newborn after birth. All right, what is the pathophys? Well, the pathophysiology, the firstborn newborn is rarely affected. Because the maternal blood system needs to be sensitized to the incompatible fetal RBCs from a previous pregnancy with an Rh positive fetus. If a mix of incompatible fetal maternal blood occurs, mother is said to be isoimmunized or sensitized, which means the mother's system has produced antibodies against an Rh positive fetus. Exposure to a future fetus with Rh positive blood as a foreign object would lead to what's called hemolytic disease of the newborn, also known as erythroblastosis fetalis. Okay, let's talk about hemolytic disease of the newborn. It is due to an Rh incompatibility leading to the destruction of fetal RBCs. It occurs subsequent to maternal Rh negative blood and a previous pregnancy of an Rh positive fetus with a mixture of maternal fetal cells in the last pregnancy. One caveat to add to this: the mother did not receive a RhoGAM after her last delivery. Issue would be with the next pregnancy carrying an Rh positive fetus. The antibodies already created by the mother's system cross the placenta and destroy the fetal red blood cells. Most extreme form leads to lysis of fetal newborn red blood cells, anemia, with enlarged liver and spleen, could lead to hydrops fetalis and hyperbilirubinemia. Prevention is attained for future pregnancy by administering RhoGAM to all Rh negative mothers at 26 weeks of pregnancy, after the delivery of an Rh positive fetus, after a loss, or after any invasive procedure while pregnant. ABO incompatibilities, what we see here is the ABO cells have larger antibodies that do not cross the placenta, so these babies are not born with the anemia like the Rh incompatibility fetus, rather develops the destruction of red blood cells after the mix of maternal and fetal cells at birth. Infant of the diabetic mother. In pregnancy, glucose is poorly controlled in the first trimester. A neonate born to insulin-dependent, uncontrolled diabetic mother or a GDM mother may be at high risk for pregnancy and delivery complications, some of them due to macrosomia. We also see babies that are born to uncontrolled insulin-dependent diabetics may have cardiac anomalies and what is called caudal regression syndrome. Macrosomia occurs as exposure to high levels of maternal glucose cross the placenta to the fetus, causing these babies to be large and at greater risk for birth trauma. The other issue that we see is babies may be born large, but not necessarily ready to breathe on their own. We call them fragile giants. So their size is deceptive. Even though the baby may look and weigh term size, the immature lungs are not able to support respiration, and subsequently they will get what's called RDS. And we'll talk about that a little bit further on. We're also looking at babies that once that cord is cut and the maternal glucose is no longer going to the baby, some babies may develop what's called hypoglycemia. At birth, we'll have a decrease in glucose levels secondary to the cord cut and the maternal glucose supplies. Should stabilize between 40 and 60. What are some of the things that we see with hypoglycemia? Jitteriness, tremors, temperature instability, and cyanosis. In this slide, we're talking a little bit about preterm infants. Our goal is to prevent a birth before 37 weeks. Before that, the preterm babies will experience many short and long-term problems in the future. Why do we see preterm birth occurring? Some of the causes could include poor maternal choices, lack of sources and knowledge, and maternal disease. Preterm infants are very stressful. They're stressful on the baby, obviously, and also on parents. Now we've got a baby that doesn't come home as anticipated, excuse me, but rather is admitted to NICU. So what do we do what are we supposed to do? What is nursing to do? We are to promote oxygenation, administer surfactant when it's necessary. Maintaining temperature is of most importance, so drying with warm towels and observing for signs of cold stress. Okay, some of the common problems that the preterm infant will experience I have listed here. Problems are directly related to immature organs and systems. Respiratory problems are directly related to a lack of lung surfactant that increases with fetal maturity. Recall that surfactant is the phospholipid that allows the alveoli to expand and contract and is necessary for breathing to occur. With low levels of lung surfactant, premature newborns will develop RDS. Cardiovascular heart murmurs are common due to the shunts not closing. Treatment is to monitor, including blood pressure of all four extremities, especially to compare left and right and upper to lower. Thermoregulation, the preterm neonate has decreased flexion that allows the body to be limp, allowing for more cold, causing excessive use of glucose stores being depleted, leading to cold stress. Gastro, document passage of meconium and voiding, lack of suck and swallow and breathing. Remember, this is a method by which the baby has to learn a sequence, suck, swallow, breathe, in order to take nourishment in. If the babies are born too early, it takes them longer to develop that mechanism. Central nervous system, there is a lack of muscle contraction to conserve the heat. Again, we're worried about babies being cold, and immaturity and flaccid. I'd like you guys all to pay attention to pages 684 through 689, table 25.7, box 25.4, and table 25.9. This slide simply gives you signs and symptoms of preterm babies, and as you can see, there are quite a few, more than I would even want to go into one by one, so I'm going to refer you back to your text on that. Necrotizing enterocolitis, which is also called NEC, and retinopathy of the newborn. NEC is an acute inflammatory disease of the gastrointestinal tract. The pathophysiology is it is a result of an ischemic episode which interferes with digestion. The bowel develops necrotic patches, which leads to digestion impairment, perforation, peritonitis, and ileus. The assessment involves looking at the abdomen and visualizing an increased girth that is tender to the touch and tense. The infant will have poor stomach emptying and undigested milk aspirate. We also see temperature instability. Management includes NPO, an NG tube to decompress abdomen, enteral probiotics and IV, antibiotics and fluid, possible surgery, and temporary colostomy. When we're looking at retinopathy of the newborn, this is an acquired vascular disorder involving gradual replacement of retina by fibrous tissue and blood vessels, primarily caused by prematurity and the use of supplemental oxygen therapy greater than 30 days, sometimes at high levels. Assessment includes leukorrhea, which is white tissue on the retinal space, and we should be checking for the red reflex. Management is to monitor O2 levels, cryosurgery or laser therapy, and monitor at 4 to 6 months of age. Okay, here are a couple more problems, respiratory complications that premature babies may incur. Bronchopulmonary dysplasia. This is where the alveoli are damaged for prolonged exposure to ventilation. Pulmonary hypertension is severe hypertension with right to left shunt through the foramen ovale that did not close. Okay, let's talk a little bit about transient tachypnea of the newborn, or TTN. It occurs during transition to newborn life. It is caused by the incomplete evacuation of lung fluid. The retained fluids limits alveoli surface available for oxygen exchange. It usually lasts from birth to 3 to 5 days. It is more commonly seen with a cesarean delivery since there is no chest compression during, as is in a vaginal delivery, to rid the lungs of the extra fluid. Don't confuse RDS, don't confuse TTN with RDS because the symptoms can be similar, but the causes are totally different. Management is to observe closely, NPO if necessary. Further management may be dependent on patient status and causative agents. Of course, oxygen therapy would be involved in that. Assessment includes substernal retractions, nasal flaring, expiratory grunting, tachypnea, babies getting tired with feedings or poor feedings, and mild cyanosis. When we look at the treatment, it's always going to be supplemental O2 as necessary. Respiration should be between 30 and 60. If we find respirations greater than 60, we need to defer feeding since it takes the baby more energy to suck than he or she is taking in with the feeding. Respiratory distress syndrome. Let's take a look at that. As we mentioned in the past, is primarily seen in the premature infant due to a lack of surfactant. Management includes monitoring this baby's color, his or her respiratory rate, and blood gases. And of course, we're going to support through oxygenation and meds as prescribed. Talking about oxygenation, sometimes we have to place these babies on a ventilator, and even for a ventilator, it's difficult to inflate a non-compliant lung. So we have to use a higher rate and pressure, which can cause a pneumothorax, so that needs to be monitored quite closely. We can also spray surfactant into the lungs through a catheter or an endotracheal tube. Assessment always includes the symptoms of respiratory distress. We know they're retractions, grunting, and flaring. Again, we're looking for a dusky color, circummoral cyanosis, and a low body temperature. Okay, let's talk about the post-term neonate. By definition, this is a baby born after 42 weeks. One issue facing a post-term neonate is related to the aging placenta and the loss of its efficiency. The placenta has a shelf life, and that is to say the placenta functions best up to about 40 to 42 weeks. Around 40 weeks of pregnancy, the placenta will begin to calcify. With the aging of the placenta, the fetal system compensates for lack of nutrients by utilizing what it has stored up. That causes fetal wasting. Placental oxygen deprivation leads to oligo and possible cord compression. Increased RBC production, aka polycythemia, to compensate for decreased oxygen levels later may lead to neonatal jaundice. Post-term babies are prone to mixed staining secondary to the stool being so close to the rectum if they are to experience a hypoxic episode while in utero they may have a stool. This leads to fetal aspiration of meconium fluid and sepsis, which I'm going to talk about in the next slide. Okay, let's talk about sudden infant death syndrome, SIDS. We've heard a lot about this, and it's gained a lot of notoriety, and luckily we've intervened back in the 80s when they instituted the Back to Sleep, and now we've had significant time for studies to pull together some ideas, and what we see is about a 30% drop in SIDS cases since the mid-80s just by instituting this back to sleep. What is it defined as? It is an unexplained death of an apparently healthy infant under 1 year old. On postmortem, there's no apparent cause, and babies appear to be well nourished. Um, Lots of theories out there. Neurological brain stem dysfunction is probably the most recent. We've heard about genetic links, maternal smoking in pregnancy, co-sleeping. And this usually occurs while sleeping. Um, so we really don't have a good grasp on it. As I mentioned, neurological brainstem dysfunction is I think the hot topic these days. Subsequent children need to be observed closely. An autopsy can help with grieving so that they can see it's not their fault. There was nothing that happened. No malformed genes that they passed on. Family screening of babies with SIDS is a good thing. I know in the institution where I used to work at, if there was a history of SIDS in the family, usually those moms and babies would go home with an apnea monitor. For how long they kept them, I'm not sure. I do have a short story to tell you of a baby that I delivered years and years and years ago, and it just struck me as something being wrong, nothing that I could really put my finger on. But the house doctor, I kept calling him, and he would come down and see the baby, and he'd see the O2 status good, sugar's good. There's really no reason to put this baby into NICU, so we didn't. He did not. The news shift came on, and the nurse following me, I, recanted all the things that had happened during the day and the delivery of that baby, and found out later she did get the afternoon doctor to admit this baby to NICU. 2 days later, the baby was getting ready to go home, was still in NICU in an open crib, had an episode of stop breathing. And in the NICU, they did everything that they could possibly do. They worked on that baby for almost an hour and could not bring the baby back. So it was a loss. So, needless to say, a true SIDS is sometimes out of our hands and with a higher power, but that doesn't negate us from doing everything that we can um, for those kinds of babies. This next picture, I think, is just so lovely and serene. Um, it depicts a mother and baby in bonding, and you will learn in PEDS next year that the first year, that bonding and that developing trust between a mom and a baby really does affect the rest of their lives. It's just that important. I want to talk about a topic now that isn't really um, one of my favorite, but it does need to be talked about, and that is intrauterine fetal death. Um, the patient is often profoundly affected, and so are the healthcare workers around them. It's associated with maternal and fetal conditions. Many causes include chromosomal abnormalities, congenital malformations, long-standing maternal infections that go undiagnosed, immunological causes, and complications of maternal disease. Usually the detection is found or completed at a prenatal visit. Presenting symptoms are no fetal heart rate, no movement on ultrasound, painless maternal vaginal spotting, and or no fetal movements. Management includes induction of labor and a vaginal delivery when possible, and to assess the mom for DIC, which is caused by a breakdown in fetal tissue. Nursing care of the grieving family. Abnormal grief reactions may lead to abnormal mothering behaviors with other children. So we want to promote normal grieving by first facing our own feelings about death. Second, don't be afraid to express that emotion. And reassure people that it's okay to cry. Use touch. Encourage to make arrangements on when they choose to, provide privacy for the family, and call the baby by name. These families are at risk for abnormal bonding, increased child abuse, and increased failure to thrive syndrome. Perinatal loss. Parents can experience intense grief after the death of an infant. The three stages of grief are often overlapping. That's acute pain distress, intense grief, and beginning to deal with death. I have a colleague who I've known for better than 35 years, and one of the first years we worked together at a hospital, we had one of the first intrauterine deaths that came in. She decided to take care of this patient, and I just wanted to tell you about this. She ended up being Nurse of the Year by the state of Michigan based on the letter that the mother wrote to the state of Michigan about the nursing care that she received with the loss of her child. We impact families both when they are experiencing joy and grief. Further things to talk about when we look at care of the grieving family. Management allows to express feelings of pain and anger, facilitate the grieving as mentioned before on their timeline, provide mementos like taking pictures, lock of hair if it's available, foot and hand prints, ID bands, and hat and booties. Encourage them to spend time with the baby and provide them with accurate information. This picture was taken, and it's all around the internet. I just think it's very cool. This, I have to imagine that they were treating this infant for something in utero. The thing that comes to my mind is anemia when we talked about the Rh incompatibility and erythroblastosis fetalis. But it is amazing to me the things that we can actually do to help these babies even while still in the mother's womb. This last slide, really I have nothing to add to it. This is just a list of signs and symptoms if you should happen to see that require immediate medical attention. And that's the end of today's PowerPoints. Thank you for your attention.